Good morning, everyone. You are very welcome to the launch of the Rapid Review and Updated NCEC Adult Type 1 Diabetes Mellitus Clinical Guidelines and of the newly updated Integrated Model of Care for People with Type 2 Diabetes Mellitus webinar. The panel would be delighted to receive any questions you may have. Please use the Q&A feature located at the bottom of your PC laptop screen. If you are using an iPad, you will find this feature located at the top of your screen. Without further ado, I will now hand you over to your host, Professor Derek O'Keefe, Clinical Lead, NCP Diabetes. Thank you.
Now, good morning. Welcome, everyone. We're very excited to have you with us here today. My name is Professor Derek O'Keefe. I'm the National Clinical Lead for Diabetes and Consultant Endocrinologist at University Hospital Galway. And I want to welcome you to this meeting where we're going to launch these evidence-based collaborative documents for type 1 and type 2 diabetes that we've developed over the last year with a large multi-stakeholder group of people with diabetes, advocates, academics, and clinicians. And I would like to first thank our excellent chairs for their work on this, Dr. Owen Noctor for the type 2 guidelines and Dr. Kevin Moore for the type 1 guidelines. And of course, then the whole NCP team themselves. So without further ado, what I'd like to do is just share the agenda of our meeting that we're going to have for the next 45 minutes or so. You can see here we have a range of speakers who represent both the national program in the HSE for integrated care and then also the members of the multidisciplinary team. We have voices from people with diabetes and across the range of clinicians that were involved in the development of these model of care and NCEC guidelines. So welcome, and without further ado now, I'd like to introduce you to our first speaker, Dr. Sarah O'Brien.
Thanks, Derek. Good morning, everyone. I'm Dr. Sarah O'Brien, the National Clinical Advisor for Chronic Disease. I'm really delighted to be here today to support the launch of the Integrated Model of Care for Type 2 Diabetes and the National Clinical Guidelines for the Management of Type 1 Diabetes in Adults, two key documents which will support the delivery of high-quality, evidence-based and person-centred care for individuals living with diabetes in Ireland. So I'm going to focus on the integrated model of care for type 2 diabetes, which you can see there. This model of care describes the end-to-end pathway for individuals who are living with type 2 diabetes and sets out what an individual, their family and identified supports can expect from their healthcare services if identified as being at high risk of developing or if they have already been diagnosed with type 2 diabetes. So at the base of the model, there is a clear emphasis placed on the prevention of illness and complications and supporting individuals to live well with type 2 diabetes through, for example, brief interventions and self-management supports. At level 1, this is an important component of our model, the very successful structured chronic disease management program in general practice, which I know Dr. Lisa Devine is going to speak to in more detail. But suffice to say, at this point, this program is having significant positive impacts on supporting patients to improve their health and control of risk factors through demonstrable reductions in measures such as the HbA1c, obesity, and high blood pressure. At level 2, the community specialist ambulatory care is a new layer of care in the community to support patients in managing their diabetes. These teams are offering more timely access to specialist and multidisciplinary opinion in the community to support hospital avoidance. Referrals to this level of care might be considered for individuals who, for example, have a known diagnosis of type 2 diabetes with increasing complexity or complications associated with their conditions. These services are free to the full population where clinically indicated. And it's expected that these additional diabetes resources in the community will deliver improved access to high quality type 2 diabetes care in the community, removing the need for repeated outpatient appointments, thus freeing up capacity in the hospitals to support more timely access to specialist opinion for management of more complex type 1 diabetes or type 2 diabetes or multimorbidity. It's also important to note that at this level, there are also cardiology and respiratory chronic disease community specialist team members who are co-located alongside the diabetes team members and will work together to support patients who have more than one chronic condition to really deliver care that meets the patient's needs and reducing that burden for patients of having to attend multiple different specialist appointments for their different conditions. At level 3, Acute specialist ambulatory care will provide multidisciplinary care for the highest complexity of diabetes that cannot be safely cared for in the community setting and requires long-term follow-up in the hospital setting. So, for example, this might include an individual with type 2 diabetes who requires ongoing titration of insulin. At level 4, at the top of the pyramid, acute hospital admissions won't always be avoided, but the focus of this model of care is always on delivering person-centred care at the appropriate level of complexity in line with Launch Care. So the aim is to support early and timely discharge and follow-up in the community as soon as is clinically possible. Just to finish, I'd like to thank all those who have led on the delivery of this model of care. A particular thank you to Professor Derek O'Keefe and Ms. Dervla Kennedy and the National Clinical Programme Diabetes, who provide essential clinical leadership in improving patient outcomes through their work on the programme. A big thank you also to Dr. Owen Noctor, who has led this model of care through to publication. The model of care being presented today has had significant input from a wide variety of stakeholders, as you heard from Derek, over a number of years. So to all those who have contributed, a very sincere thank you. As the clinical programme for diabetes now shifts its focus to supporting implementation of this model of care, I hope we can count on your continued support in supporting the delivery of improved care and care outcomes for patients living with diabetes. Thank you very much.
Thank you very much, Dr. O'Brien. So next up is the National Clinical Director, Dr. Siobhan Ní-Bhríon, who served both on the NCEC and the Type 2 Model of Care committees. Thank you.
Thanks, Derek. And it's a great pleasure to be here today. It's always lovely to be at an event launching a model of care because it's a happy occasion that brings everybody together to celebrate the work that's been done in achieving our milestone models. So I'm here today as a National Clinical Director for Integrated Care and as a member of the National Clinical Effectiveness Committee. And I'm really delighted to be launching both the Integrated Care Model for people with type 2 diabetes mellitus and the 2024 update of the NCEC guideline of the original 2018 guideline, number 17 for type 1 diabetes in adults, along with its implementation plan. Just to note that a recent Lancet article described diabetes as a defining disease of the 21st century, the prevalence of which is increasing significantly. We need to work together as a team to prevent diabetes across our population, that's type 2 diabetes, to support the early diagnosis for those with type 1 diabetes and indeed type 2 diabetes, and provide evidence-based intervention to people with all types of diabetes to maximise on their quality of life. Using our Scottish prevalence information and applying that to the Irish population, it gives us an indication that approximately 300,000 people in Ireland are living with diabetes. Approximately 10% of these would have type 1 and 90% would have type 2 or maturity onset diabetes of the young. I'm going to turn first to the model of care, which was developed by a multi-stakeholder group of over 30 people, comprising of people who are expert by experience, healthcare professionals across all levels in the health service, advocacy groups, including Diabetes Ireland, reps from the higher education institutes. It was very ably chaired by my colleague, Dr. Owen Noctor, a consultant endocrinologist based in UHL, and supported by our clinical lead for diabetes, Professor Derek O'Keefe, and the excellent NCP team, who's led by Dr. Sarah O'Brien. The updated model incorporates recent advances in the management of diabetes, including medications, for example, the GLP-1 agonists, updates in the healthcare system, and changes in our strategic landscape for the management of chronic diseases. Implementation is already happening with the national rollout of 30 diabetes community specialist teams in the ambulatory care hubs, and we're well on the way to staffing those teams. Moving on to the guideline, as I've said, it is an update of the 2018 NCEC National Clinical Guideline number 17, type 1 diabetes in adults. This guideline was unique in that it was the first and only to date NCEC guideline to follow a process of contextualization by adapting the guideline from England's National Institute for Health and Care Excellence guideline of the same title to the Irish setting. This has proved to be a very effective partnership, with an excellent guideline being produced following the hard work and dedication of many who are here today. In 2021 and 2022, NICE updated their type 1 diabetes guideline, and the Irish Guideline Development Group then reformed and engaged with the Clinical Effectiveness Unit of the Department of Health and the NCEC to make the same corresponding updates to the NCEC National Clinical Guidelines. The update project was again carried out via the collaborative process with NICE. The rapid update to this guideline was approved in February 2024 at the meeting of NCEC, and our committee members included our chair, Professor Jerry Fitzpatrick, who's an old colleague of mine from Tallaght Hospital. Unfortunately, Jerry couldn't be here today due to prior commitments, but he sends his apologies. And the entire team, including myself, were very impressed by the commitment of the Guideline Development Group, the continued enthusiastic engagement with the CEU and the department to turn this project around under relatively tight timeframes. And I think it would be fair to say it was one of the fastest guidelines we've ever approved, in my experience at NCEC. So it really was a pleasure to be there. And I have to say, I was proud of the clinical programme and turning the guideline around so quickly, along with the CEU and colleagues from NCEC. The guideline itself brings the updated and evidence-based and quality-assured recommendations from the NICE guideline around continuous glucose monitoring into the Irish practice. The recommendations also back up the findings of health technology assessments done by HIQA, which were specific to Ireland. And an important part of the robustness of the NCEC guidelines is their associated implementation plan. This 2024 update of the NCEC guideline also updates the implementation plan for the original 2018 guideline. The implementation of recommendations relating to CGM from the 2024 rapid update to this guideline will be guided by our colleagues in the Medicines Management Practice Programme, with guidance for the Managed Access Programme for all CGM systems for individuals with type 1 diabetes. And I'm delighted to say this is one of many collaborations we have between the National Clinical Programmes and the MMPE. Just to note, for those who aren't familiar with the National Clinical Effectiveness Committee, it was set up as a result of a ministerial committee in 2010 as a key recommendation to the 2008 report of the Commission on Patient Safety and Quality Assurance, also known as the Madden Report. And it is a key partnership between stakeholders who have an interest in patient safety, a mission to provide a framework for national endorsement by the Minister for Health of clinical guidelines, and a clinical audit to optimise patient and service user care. This is one of a collaboration that we have between the clinical programmes and NCEC. And again, it is fantastic to have the opportunity to develop models of care along with clinical guidelines that have that national imprimatur. So I'm going to conclude by thanking my colleagues Dervla Kennedy, Derek O'Keefe, Kevin Moore and Tomás Griffin, who liaised extensively on behalf of the NCP with the Clinical Effectiveness Unit in the Department of Health. I also want to note the great work of Owen Noctor, Yvonne Maloney, Assumpta Coyle, Lisa Devine, and all those who participated in the MOC Development Group. It's a fantastic achievement. I want to thank the team in NCEC, who are always such a pleasure to work with. And I have to say, have lovely tea and coffee whenever we go down for our meetings in person. Not always pastries, folks, let me say, just fruit and other healthy food as well. And a huge thank you, particularly to Orla Dwan and all our service users and advocacy groups who participated and are our most important advisors in the development of our clinical guidelines and models because of their experience, their expertise by experience. I want to, on behalf of myself, my team in clinical design and innovation, and the whole chronic disease management team, wish Dervla, our programme manager, the very best of luck in the coming weeks. And I hope she has a wonderful summer with your new family member, Dervla. I'm delighted you were here today. I was a little bit worried you weren't going to make it, so it's fantastic you're here for the launch. Thank you, Derek.
Thank you very much, Dr. Negrian. Lovely words. So up next is our chair of our type 1 diabetes guidelines. I'd delighted to introduce you to my colleague, Dr. Kevin Moore.
Thank you very much, Derek. Now, just make sure I'm clicking on the right one. Lovely. Okay.
Perfect, Kevin. Thank you.
Thank you very much. Lovely. Okay. So now can I actually see my slides? Apologies now. Bear with me for 1 second. So do you know what? I will let someone else maybe, or I'll attempt to manipulate my slides, but if needs be, perhaps someone else can guide me because I just can't see the screen, but I have them here beside me anyhow. So good morning, everyone. It's a pleasure to be here and a relief to be here today to launch the update of the adult type 1 diabetes guidelines, but it's also fantastic to participate in the launch of the type 2 model of care that we've been waiting on for a number of years. So the purpose, I've just changed the slide there, the purpose of this guideline is to provide healthcare workers, patients, and also healthcare managers with a template for what high quality diabetes care looks like for people with type 1 diabetes. And we delivered that in 2018 with the fantastic help of NICE and NCEC, but it's 6 years down the road now, and it's obviously appropriate at this stage that we carry out this update. And I would agree with what Siobhan said. I think that we as a group, as a writing committee, and everybody from NCEC and NICE have done a fantastic job of getting this update over the line incredibly efficiently. And, you know, I mean, I think for anyone trying to participate in writing or updating guidelines, you know, you want to be efficient. There's no need for us to reinvent the wheel on a lot of these things. And it's just great to see that we got the job done as efficiently as we did. The update is critical. We want to keep the information within the guideline valid and relevant. And I think we have an excellent product here in the end result, in the end guideline. I want to hone in on three aspects of the guideline, and that are the three priorities for implementation. The first priority that we identified was to ensure that all patients with type 1 diabetes have access to continuous glucose monitoring. And we all know, because this is becoming a reality throughout the country, how important continuous glucose monitoring is in helping people to navigate the high level of glucose fluctuations that are present every day for patients with type 1 diabetes. So I think this is a really important recommendation for all of our patients. The second recommendation was to recommend that all patients with type 1 diabetes have access to structured education. Really in Ireland, what that means is that everyone with type 1 diabetes has access to Daphne. And Kathy Breen has a video further down to update us a little bit on what's going on with Daphne. But I do think that we need to start putting our heads together and have more conversation between our level 2 and level 3 hospitals with our level 4 hospitals to ensure that we're kind of streamlining and coordinating the effort that's going into delivering structured education across the various hospital groups. The third priority that we want to hone in on is to ensure that our patients have proper access to care. Now, the type 2 model of care has done a beautiful job of ensuring that patients with type 2 diabetes have access to 2 visits per year at a primary care level, plus additional visits as necessary within the hub or the hospital setting. And really what we need to do is we need to think about matching that for our type 1 patients who are equally, if not more complex in their individual needs. So our recommendation has stated that patients with type 1 diabetes or adults with type 1 diabetes should have access to a minimum of 2 consultations per year with a diabetes healthcare professional. And I think that that is a really important recommendation. So, the model of care for type 2 diabetes within the document has stated that its aim is to outline the spectrum of best practice care and service for type 2 diabetes mellitus management in Ireland, ensuring the right care in the right place and at the right time. And I think what we should be doing is thinking about what a model of care for type 1 diabetes would look like. And for me, that would mean the right care, as we've described very eloquently, I think, in our new type 1 diabetes guideline. The right place for type 1 diabetes care, well, I think we're all in agreement that that needs to be with the hospital-based diabetes teams. And the right time, as I've already just stated, is a minimum of 2 consultations per year with their diabetes healthcare team. So really, I don't think today is about launching an update for type 1 diabetes or, for that matter, launching the model of care. I think with today, the challenge is to ensure that every diabetes team throughout the country is reevaluating the level of diabetes care that they're currently providing. And more importantly, I think they need to think about redesigning their diabetes service to ensure that the care that they're providing is in line with not only the type 2 model of care, but also the recommendations that we have contained within our type 1 diabetes guideline. Okay, so I just want to finish then by thanking a few people. First of all, the members of the update team for the guideline development group. I also want to thank not only NICE for putting together such an excellent guideline, but the contextualization committee that they had, who were so easy to work with. I want to thank NCEC for making this, making the original document possible, and for helping us with this rapid update. And finally, the National Clinical Programme, and in particular, Derek and Dervla for their outstanding work, not only on this guideline, but really throughout their tenure, they have done incredible work, and we, the diabetes community, are so grateful. Thank you.
Thank you very much, Dr. Moore. So great work done, and well done to you and everyone on that committee for producing such a valuable document for people with diabetes type 1 in Ireland. Up next, so, is the chair of the type 2 model of care, Dr. Owen Doctor.
Thanks very much, Derek. Hopefully you can see my slides there. I'd just like to say I'm delighted to be asked to present today on behalf of the Type 2 Diabetes Model of Care Group. It was an absolute privilege to be involved and to be asked to chair by Derek and Dervla, without whom your tireless efforts would never have gotten this over the line. So thank you very much. And
Dr. Owen, apologies.
yes.
Can I get you to just pop that into presentation mode for me, please?
Yeah.
There you go. Thank you kindly. Sorry.
No worries. So what I'll concentrate on today is an overview of the process and the main points, and hopefully where it has an impact on people living with diabetes and their care. So we were in the privileged position in that we were providing an update on the model of care for type 2 diabetes. So we had huge amounts of work to build on, great work that had been done previously by different iterations of this model. The last one was 2018, so we had a little bit of ground to cover. I think we all know there was quite significant developments in care of people with diabetes since 2018, and we were tasked to capture this. So that was one of the really positive things about being asked to take this on. There was so much there that we could build on. Secondly, and this provided us with a map for the process, really. There was national guidance on the development of models of care from the HSE since 2018. So this provided us with, well, what does model of care look like? What does it say? And this really guided us in that regard. Basically, we had to incorporate evidence-based guidelines, pathways and required services, and we had to make sure that this covered the condition course across the lifespan and across everywhere where people accessed care, so primary, secondary, and tertiary care. And we hope we've done that with this. So it's Launch Your Care. I won't go into the details here because I think everyone is familiar with this. It's one of the huge changes in the Irish health system since the last model of care. But I think if we can boil it down to one thing, it's the right care for the right person in the right place at the right time. And I think everyone very much had that as a guiding principle throughout the development of the document. There's far too many people, unfortunately, to individually thank, and the document contains the details of those who were involved at every level. But it was just an absolute pleasure, I have to say, to be part of this team. We had huge numbers of people from all different aspects of diabetes care, and everyone gave their expertise freely, repeatedly, emails, day, night, calls, and I was just absolutely blown away by how much time and effort everyone involved put into it, and I think I hope that shows when you read the document. This pyramid is familiar to, I think, everyone now, but I won't dwell on it. Dr. Sarah O'Brien and Dr. Siobhan Green have alluded to this in their excellent presentations this morning, and thank you. But this provided us also with a way to divide up into work streams. So we had level 0, living well with chronic disease, so living well with type 2 diabetes, the general practice and primary care team, community specialist ambulatory care team, acute specialist ambulatory care, hospital-based and specialist hospital care. So this provided us with a very natural breakdown of the work streams. But in truth, there was such wide discussion in the group and across the work streams that I think every group benefited from everyone's expertise. So and that was one of the real strengths and something that stood out to me throughout the process. One of the key things that changed in this model of care that I'd just like to focus on is the model of care in 2015 set out a cycle of care for type 2 diabetes. So why was that important? Well, for the very first time, actually, that set out who should be looked after, where. And you had a very clear complicated diabetes pattern in hospitals that included type 1 diabetes, although not included in this model of care, pregnancy and others. Technology was in hospital care, and complex foot disease, for example. Then there was uncomplicated type 2 diabetes, defined as 2 oral agents and well-controlled HbA1c with no stable complications. Should have been looked after in primary care. And then in the middle, you had integrated care, and it set out for the first time the 3 visits per year model, and hopefully provided some structure for patients to be looked after outside of a hospital setting, but with a high level of care. So this was a huge step forward. One of the things about this was defining that orange area in the middle, complicated type 2 diabetes, meant different things to different people, and there was different local practices also that incorporated. So that was one challenge in implementing this, and also it was largely, not exclusively, but largely one direction. So when your needs outgrew one level, you proceeded to the next level. Now, I think everyone involved in diabetes care will know that that doesn't necessarily reflect how diabetes is. These are all the same people. It's just at different stages in their lives or in their journey with diabetes. And that's hopefully what we have tried to reflect in this model of care. And enabling this was the huge funding and incredible work that has gone into developing integrated care in Ireland in the last couple of years. And it's just absolutely unprecedented. I don't believe I've ever seen a model like it anywhere in the world, the work that's gone into it in such a short space of time. So it really is transforming care, and hopefully we can contribute to that with this model of care. But the change from previously is that hopefully we can now capture that this is a journey across primary care, across secondary care, across tertiary care, and across somebody's lifespan, and different challenges, different times, and all in keeping with the Launch Care principle of the right care from the right person at the right time. And the Integrated Care Hub facilitates this, and this is going to be one of the key changes. We have healthcare professionals established in the hub. Many hubs are up and running now to a very high degree. And this provides a middle ground between primary care and the hospital, and provides personnel who work across these sectors. So again, if you are a person living with diabetes, this hopefully provides as seamless a care as possible. So your needs, where you go is determined by your needs and not by a local process, not by a national process, not by a postcode, but what you need. And hopefully this is a step in that direction for everyone living with type 2 diabetes. So the brief for the model of care was to provide evidence-based guidelines. Kevin mentioned reinventing the wheel. We didn't want to do that. So we extensively reference large society guidelines and contextualize them for Ireland. Pathways and required services are set out. And again, you see the population pyramid and how people access care at different levels. Across disease course and lifespan. This hopefully is reflected in the document as well, that your needs change at different times and how you access care changes. And across primary, secondary, and tertiary care, well, I think this is really, if I had to pick out one thing, I think this is what the model of care in 2024 has hopefully provided, that this is the start of a journey where people with type 2 diabetes access the care they need, no matter where it is and no matter where they are. So I'd like to stop there, and I'd like to thank everyone today, all the speakers today who have covered some fantastic ground. It's great to see the type 1 diabetes guidelines also. I would like to thank Derek and Dervla from the National Clinical Programme for Diabetes for getting this over the line. And of course, the Dr. Sarah O'Brien on behalf of the NCAG office, and Dr. Siobhan Breen on behalf of the Integrated Care. So absolutely delighted to be part of it, and thank you.
Thank you very much, Dr. Akhtar, for your tireless work and your enthusiasm for the entire process over the last year with the model of care for type 2 diabetes, a major piece of work. So well done. And now I'm delighted to introduce the voice of the person with diabetes and carer, who was a big part of our multi-stakeholder group, Ms. Orla Dwan.
Great, thank you, Derek. Good morning, everyone. Thank you to the National Clinical Programme for Diabetes for inviting me to speak here today from a dual perspective of a carer, family member of someone with type 2 diabetes, and also as a patient advocate, as I have type 1 diabetes myself. I would just like to say I'm actually stepping in this slot very last minute, so please bear with me. But living with diabetes teaches us some great skills, quick decision making, and adapting on our feet go hand in hand. And they're also skills which are cultivated by carers, so they're very helpful for me today. I'd like to give a special mention to Kate in Diabetes Ireland, who should be presenting now, from the dual role from both the type 1 and the type 2 working groups, but also as her role as the Research and Advocacy Manager in Diabetes Ireland. And with her background as a clinical psychologist, while also living with type 1 diabetes. She has combined role of the lived experience with professional knowledge. It was Kate who reached out to me a few months ago, encouraged and recommended I join the National Clinical Programme for Diabetes Type 2 Working Group. So as a newbie and a latecomer, I have to personally just thank Kate. So even though I have diabetes over 3 decades, it was actually through my dad's rather dramatic medical emergency with DKA, diabetic ketoacidosis, something considered rare for type 2 diabetes. This set the seeds for diabetes awareness and advocacy. The structured diabetes education I received a few years prior taught the importance of blood ketone testing, something I was unaware of at the time. And I have a sincere thank you to diabetes nurse specialist Jenny O'Mahony for that education, as this training will prove invaluable with my dad's story, especially during a time we experienced diabetes staff shortages. The education, notes for sick day rules, and insulin adjustments for steroids were pulled out and used. Overall, there was a double return on that investment for me personally and in my pursuit of an insulin pump, but it also gave me tangible skills that I was able to utilize when caring for my dad's diabetes at home. Co-creating healthcare and collaboration between various multidisciplinary teams is something I became more aware of as a caregiver, and the benefit of having access to official clinical guidelines. So it is a great honor to have carers' voices added to such a large and varied working group, where each person has invaluable input to bring to the table and are treated with courtesy and respect. Many will be familiar with the saying, "There is nothing about us without us." And there have been many diabetes advocates who have helped pave the way for me and others. Valerie Humphreys is an amazing and eloquent voice for the type 2 diabetes community and part of the National Clinical Working Group for type 2 diabetes for many years. We have many wonderful patient advocates in the diabetes community, known as the DOC, for anyone who doesn't know. And one area we can really unite in is to help stop the stigma. No one wants to have diabetes, yet we find ourselves in this unique club where unfortunately stigma still exists. Language matters, it really does. And it's great that we actually have an official Language Matters document released a few months ago as well. And why having patient voices represented in the framework of national clinical guidelines and having the support of healthcare professionals, where we try to sing from the same page in support of improved equality and equity of care. Coordinating the working groups would not be possible without Dervla, the manager over the National Clinical Programme. Administration and coordination are a big part of a caregiver's role, and they often go unnoticed. So for me, it's been very easy to see and recognise the wonderful work Dervla has done in bringing the model of care guidelines to the finish line, along with Professor Derek O'Keefe and Dr. Owen Noctor as a chair of the Type 2 Working Group. And if anyone, when you look at the final document, you will see this is a very, very large working group. So all I can say is well done and thank you to everyone involved. In finishing, I would like to thank the various diabetes teams involved in both my late father's care and mine. The staff, including the podiatry and the retinopathy team in Diabetes Ireland Cork Care Centre, who have always been of great support. And special message, I suppose, to the diabetes community and those who might lurk in and stuff. All I can say is that there is a place for your voice to be used and heard. It may be low key or it may be national, but I would encourage you to find it and don't be afraid to use it. I have been told I found my voice within the adversity of my parents' story. And sometimes we need an urchin to produce a pearl. There is a place for you, and I would just encourage you to step into that place. And with that, I will close and hand you back to Professor O'Keefe.
Thank you so much, Orla. They're beautiful words. And it is so important to have, you know, the person with the condition involved with the development of the guidelines. I think Ireland has been a true trailblazer in this with the development of these particular model of care and guidelines. And it is important because, you know, people who are clinicians, they're obviously the specialists in the disease, in this case, diabetes, but the patients with the condition are the experts. And I think that's really important to have that expert voice at the table when the guidelines and the model of care are being developed. So thank you very much, Orla, to you and all your colleagues that you mentioned there. Right, so up next we have our National Clinical Lead for General Practice in Diabetes, Miss Lisa, or Dr. Lisa Devine.
Thank you for inviting me to record a short video for the launch of the new model of care for type 2 diabetes. Lisa Devine is my name. I'm a GP and the ICGP HSE GP lead for diabetes. It was my privilege to join this multidisciplinary working group made up of people living with type 2 diabetes, advocacy groups, academic colleagues, and a wide range of healthcare professionals. I would like to pay tribute to the clinical leadership provided during this project by Dr. Owen Noctor and Professor Derek O'Keefe, and the tireless work of Miss Dervla Kennedy in bringing this together. I was delighted to lead the Level 1 group, which focuses on primary care. Our patient lived experience perspective provided by people living with type 2 diabetes and advocacy groups were invaluable in making sure that we kept patient-centred care at the forefront of our minds throughout the creation of the model. The model also focuses on the role played by the Chronic Disease Management Programme, and we can see huge improvements already from the CDM programme, which is provided through general practice. Nearly 123,000 reviews were provided in 2023 by GPs and their practice nurses. And we can really see the improvements of this in reductions of HbA1c of 45% over only 3 CDM visits. And we are also seeing a reduction in hospital admissions and readmission rates amongst people attending for chronic disease management care. This model of care really recognises the contribution of GPs and their practice nurses in balancing the provision of chronic care with all of the different clinical obligations and non-clinical obligations they face on a daily basis. Ensuring that GPs and practice nurses are given a task of correct complexity and in line with the CDM contract was all important, and this was at the centre of the provision of the new model of care. The wider MDT is an essential part of Level 1, and their provision of quality care to patients and their support of general practice is invaluable. The exciting development of the new CDM hubs will also serve to enrich patient care and support the general practice team. The model of care also recognises the challenges and limitations of our current way of working. In particular, it acknowledges the omissions of non-card holders from attending for CDM. Although the inclusion of women with gestational diabetes, independent of card status from the 1st of January 2023, is a huge step in the right direction. Other challenges acknowledged in the model is the need for ways of working with vulnerable populations who are attending for CDM care. The new model of care for type 2 diabetes also identifies several opportunities, such as the inclusion of pharmacists in providing direct support to GPs and practice nurses via the iSympathy model. This was also something which was considered in the model, although it is not current practice. Overall, I think the model of care really summarises the best practice for people living with type 2 diabetes in the context of our current healthcare system. I would like to thank again all of the people who made up the working group for all of their hard work. And I want to thank you again for inviting me to speak today.
Okay, thank you very much, Dr. Devine, for your insightful words there on the GP part of the development of the guidelines. As you said, it's multi-stakeholder, so important to get everyone's input. Okay, up next is Miss Yvonne Maloney. Yvonne, if you want to take it away.
Yvonne, you're just on mute there. If we could ask you to unmute yourself, please. Thank you.
Now. Good morning. My name is Yvonne Maloney. I'm an advanced nurse practitioner at University Hospital Limerick, and I'm speaking this morning on behalf of my diabetes nursing colleagues and my colleague Joanne Lowe, who is a clinical nurse specialist in integrated care in South East Dublin and Wicklow. Both of us work on the National Clinical Programme as nurse leads. We really welcome these two documents, both the updated version of the Type 1 guidelines and the updated version of the integrated care model of care for people with type 2 diabetes. They're excellent resources that will help us to streamline our diabetes nursing processes and continue to provide safe, high quality evidence-based nursing practices delivered by clinical nurse specialists and advanced nurse practitioners across the acute care setting and the primary care and secondary care settings. We use various different pathways which have been already developed by the Enhanced Community Care Network. Example, the Model for Foot Care and others. These guidelines and the model of care will also help us to achieve our diabetes nursing goals as a regulated profession using the Code of Professional Conduct, which is developed by the Nursing Midwifery Board of Ireland, and our scope of practice, which are on the bottom of the slide, and also the standards for advanced practice in nursing. The guidelines and the model of care will also feed into our non-clinical roles, which include education of the multidisciplinary team and the nursing staff, and clinical audit. Clinical audit to ensure that we're providing the high quality care that is expected of us. And furthermore, to develop advanced nurse and general nursing research as part of our roles. We look forward as diabetes nurses to work with our patients and with the people that live every day, 365 days a year with diabetes. Thank you for this opportunity to speak and to work on the guidelines and the model of care. Thank you.
Thank you very much, and great to get the insight of nursing and AMPs in the development of this work. So thank you very much for your contribution. Next is Dr. Kathy Breen, the dietitian lead for the NCPCD.
Hello, everybody. My name is Kathy Breen, and I'm the interim dietetic lead with the National Clinical Programme for Diabetes. I'm really sorry I can't be available at the launch today. I'm actually on a flight as you're watching this. So even our connected world, it wasn't possible for me to be there. So this is a pre-record. I have just 2 slides today. And I suppose in the first slide, I'd like to acknowledge the key role of dietetics in multidisciplinary end-to-end care across both community and acute pathways in type 1 and type 2 diabetes. Looking at the chronic disease model, dietetics are involved in care delivery at all levels. Inpatient type 1 diabetes with medical nutrition therapy, DAFNE delivery, and diabetes technology. In type 2, again, with medical nutrition therapy and structured self-management education programs such as Discover Diabetes. Nutrition needs change across the life course, and pregnancy and aging are great examples of the need for modifications in both nutrition and diabetes care, which will always require input from dietetics. Dietetics are also involved in the delivery of the National Diabetes Prevention Programme and Best Health Obesity Programmes. And underpinning that are also involved with training for MEC and information and supports for the public via HSE HZ. Our key role as part of the multidisciplinary team across all levels is in translating the science of nutrition in managing chronic disease as part of evidence-based diabetes care. Empowering self-management is much more than just advice giving in relation to nutrition. It's about promoting competence and confidence, the language we use, and how we communicate. And I'm always very proud to say that alongside clinical care, dietitians in Ireland work within their teams on ever-evolving service audits, development, and delivery. And that's really what the 2 documents we're launching today are about. Clinical guidelines and models of care give us a standard to work to as part of constantly improving services for people living with diabetes. In relation to the integrated model of care for people with type 2 diabetes, I'd like to extend my thanks to all of the dietitians who were members of the MDT working group, Margaret Humphreys, Karen Harrington, Liz Kirby, Dr. Ciara McGowan, Orla Brady, Suzanne Seary, and Karen Gaynor. This document supports the continued rollout of ECC and continues to recommend medical nutrition therapy and structured self-management education to support the care of all adults with type 2 diabetes, including those with increased complexity, such as more advanced kidney disease, those needing insulin, those planning pregnancy, and those with a history of metabolic surgery. And that brings with it additional CPD needs for dietitians, which are outlined in the document. In relation to the rapid update of the Type 1 National Clinical Guideline, I'd like to thank Margaret Humphreys and also Mary Finn, who were involved in the original work. This guideline again continues to recommend individualised nutrition care planning in type 1 diabetes, including CGM, which has become a key part of data interpretation in medical nutrition therapy and in DAPHNE. And to finish on a very positive note, one of the most striking things when we were completing this work is the increased availability of DAPHNE in Ireland since 2006. It's now available in 22 centres nationally, supported by funding from ICPCD. It's a really good news story for the implementation of high quality care for diabetes within the HSE. So apologies that I can't be here with you again today. I would encourage everyone to access and use the documents to guide care. And please do reach out to me if I can be of any assistance. Thank you very much.
So thanks to Dr. Breen for her input in the guidelines, both the type 1 and type 2, and then also her views and of those of our colleagues about medical nutrition therapy, a really important cornerstone of diabetes care. So finally, we have Ms. Sumta Coyle, the National Clinical Lead for Podiatry and Diabetes.
Thank you, Derek, and it's great to be with you all today. And I see there's very large numbers joining us. So I personally want to thank you all for taking the time out of your busy schedules and joining us all today. I know that all areas of the health service are extremely busy, but I also think it's really important. It's a very important hour to kind of celebrate these two documents. So just to introduce myself, as Derek said, my name is Sumta Coyle. I'm the National Clinical Programme for Diabetes Podiatry Lead, and I'm also the Podiatry Manager for the Sale to Hospital group. Lauren has kindly agreed to work with me on the slides today because technology is fantastic, but sometimes coverage may not be as strong as we want it to be. So next slide, Lauren, thank you. So delighted to be involved in developing these documents, but also from a podiatry point of view, delighted to see that from a national clinical programme, that actually that clinical leadership is being provided, and going forward, you know, to look at these documents, to have them updated on a regular basis is so important from a clinical standpoint and from a patient perspective. So delighted to see the adult type 1 diabetes document and the integrated model of care for type 2 patients living with type 2 being launched, and delighted to be asked to present today. And mainly, next slide, Lauren, thank you. So mainly, really and truthfully, just to kind of highlight, the diabetic foot model of care was published in December 2021. And the main objective of that really and truly was to provide standardized care for those patients living with type 1 and type 2 diabetes across this health service. Next slide, Lauren. And it was to provide an end-to-end approach for the delivery of care, because one of the things that we had learned is we have absolutely fantastic services and we have fantastic professionals, but really it was to standardize that care, define roles and responsibilities in relation to direct clinical work and in relation to education. Next slide, Lauren. Just really to talk very briefly about the integrated model of care for people living with type 2 diabetes. And I'm delighted to say that this aligns with the diabetic foot model of care and calls for people living with type 2 diabetes to have their diabetic foot screening and management to be primarily provided initially by general practitioners and practice nurses for those newly diagnosed, initial foot screenings and risk classification, and as part of the annual diabetes review. For the community specialist ambulatory care hubs, we can see that it is aligned that the moderate, the high risk and the in remission foot will actually be cared for within that setting. And then the multidisciplinary team within the acute setting, inpatient and outpatient care, will look after primarily and be the primary source for care for the active foot disease. So it's fantastic to see all of these documents providing kind of clinical leadership, and also that they all align and kind of work interlinked with each other to provide quality care for our population going forward. Next slide, Lauren. In relation to the adult type 1 document, it also aligns with the model of care And though the care for the patient living with type 1 diabetes is primarily within second care under the new chronic disease hubs, the foot protection podiatry team that can look after the moderate, the high risk and the in remission foot, providing care for patients living with type 1 diabetes closer to their home. And then escalating if the complicated foot becomes active, so the MDT in the hospital. And again, the type 1 diabetes version 2 guideline aligns with the model of care for the foot, which is fantastic. So we have multiple streams aligning to provide care for these patients. Next slide, Lauren. And again, just to standardize for patients living with type 2 and patients living with type 1, it is about standardized diabetic foot screening. It is ensuring that each patient receives a risk classification, that each patient receives education, that the actual postcode lottery is removed and standardization is actually brought to the fore. Next slide, Lauren. And once those patients' lower limb have been classified into a risk classification, that will decipher the team that will take leading responsibility for the lower limb health, whether it is the general practice and the endocrinology team in the hospital, the community foot protection team, or the hospital multidisciplinary foot team. Next slide, Lauren. And again, in line with both those models and in line with the diabetic foot, there is resources to support patients living with diabetic foot disease, whether they are diagnosed with type 1 or type 2 diabetes. Thank you, Lauren. Next slide. I just wanted to say thank you all again for taking the time to be with us today. And thank you for looking forward to new documents coming online and new clinical guidelines coming on. And I hope everybody gets to read these. Thank you. Thanks, Derek.
Thank you very much. A great overview of how podiatry fits, again, as a cornerstone of the model of care and the type 1 guidelines. So the first thing I'd like to do is thank everyone for participating this morning. Your attendance here shows and demonstrates, really actively how engaged you are in diabetes knowledge, education, and improving patient care. I think it's important to take a moment to also thank the government, and in particular our Minister, Minister Donnelly, who have given tremendous resources to diabetes in the last few years and continue to do so, which is fantastic. And I think that's really important to acknowledge that, given the requirements to fund the public health service and the different needs of such. So I'd like to acknowledge that publicly. I'd like to also thank especially Dr. Siobhan Vreen, the National Clinical Director of Integrated Care, for her attendance this morning and her support of the Diabetes National Clinical Programme. Of course, Dr. Sarah O'Brien, our NCAGL, for her tireless work on both of these documents. It needs to be acknowledged in the creation of the documents and then also in getting us through the systems of approval. Of course, I need to thank the National Clinical Programme of Diabetes. You've met many of those people here this morning. You've just heard from Ms. Sumta Coyle, our podiatry diabetes national lead, Dr. Kathy Breen, our dietetics national lead for diabetes. You've heard from Ms. Yvonne Maloney, the ANP for diabetes, and also Joanne Lowe should be acknowledged for her excellent work across the documents, the type 1 and type 2, representing nursing in Ireland. And then also our GP representative, Dr. Lisa Devine, who's done tireless work again across both documents. I also need to just one more time thank our chairs. These kind of jobs, when you're asked to chair these committees, they're entirely voluntary. They take a lot of your evenings and weekends. And the attention to detail and the collaborative nature is really important in these documents. So thanks to Dr. Kevin Moore for chairing our type 1 guidelines, and my colleague Dr. Owen Noctor for chairing the type 2 model of care. So thank you both for your tireless work in that. I should say that these documents are something to be very proud of. They're evidence-based and they're collaborative, and there's clear plans and resources for actually implementing them as well, which is really important. And going forward, we're going to be developing a strategy with the Department of Health to ensure that they are fully implemented in the next 5 years. And again, that's very important. Of course, I couldn't finish thanking the National Clinical Programme without thanking our brilliant programme manager, Dervla. You've heard many people thank her today because she has been a stellar person to work with. I've had the pleasure of working with her for the last 18 months as the National Clinical Lead, and again, somebody who goes above and beyond their job in ensuring that these guidelines have been produced today. So I think that's really important to acknowledge. I want to thank Dervla for her work. She's been very professional and very enthusiastic and a pleasure to work with. So thank you, Dervla. Of course, I would also like to thank the patients, the people with diabetes. Many of us professionals who work in this space, we come to work to help people with diabetes and many other conditions. But the needs of the patient come first. That's really important. And I think that's at the heart of this document. And it's been a real pleasure to be the National Clinical Director of Diabetes while these two multi-stakeholder large collaborative guidelines have been developed. And I encourage you to even look through the groups who developed them to see how collaborative we've tried to be in the development of these documents. So finally, I think it just remains for me to look back and then look forward. So obviously everything we've done today and the very existence of the program itself, we're standing on the shoulders of giants, of past members of the NCP, clinical leads, and indeed in the HSE themselves. My predecessor, Professor Sean Deneen and Orla O'Reilly should be thanked, who have recently stepped down from their roles. And then the other thing that's very important is context. So looking forward, these documents are not static documents. They will need to be revised. They haven't been revised as quickly as we would have liked because of the global pandemic, obviously. But going forward, these documents should and will be revised regularly by the National Clinical Programme. So again, thank you all for your attendance today. I encourage you to share these documents widely. They'll be available on the HSE website for diabetes. And again, they're going to inform clinical practice and improve patient care in Ireland going forward for everyone who lives with diabetes. So thank you very much.